If everything old is new again, it may be time for Lp(a). Maybe. Is it ready for prime time? I'm talking to Dr. Stephen J. Nicholls, MD, PhD, who is from the South Australian Health and Medical Research Institute in Adelaide, Australia. And he is co-author of a paper in the September 2nd issue of JACC. And it's accompanying a whole paper on the whole idea of Lp(a) as being a 25-year outcome study. This is a lot of data. Where are we right now? First off, can you talk a little bit about the paper that you were commenting on?
So, I think we see Lp(a) as an interesting factor, and we've traditionally thought that maybe it's a more powerful risk factor in younger patients with peripheral artery disease, infarcts that can't be explained by other things. But there has been a bit of a renaissance about looking at large population cohorts. We see that in this issue of JACC. Large cohort with long follow-up from Europe, suggesting that not only do elevated Lp(a) levels predict prospective cardiovascular risk, but if you actually take an elevated Lp(a) or a normal Lp(a), you can actually reclassify somebody's risk up or down in about 40% of those individuals. So it's really compelling data, it's great. In our editorial, we've kind of posed the question, so what?
Yeah.
Yeah.
Well, if you look at the guidelines right now, it's mentioned. No real recommendations. They just kind of say there's no data, so check us later. So what do we learn from this paper first off in terms of where does it have a role? Is it ready for prime time?
Well, I think it tells us that yes, it is a risk factor, and it can be very helpful, particularly in individuals who appear to be intermediate risk. We know from other parts of the literature that if you've got a very low LDL, having elevated Lp(a) may be less important a risk factor. But the two big issues for me in terms of Lp(a) are, one, are we going to actually develop a therapy that actually lowers it? Will that make a difference? If we had that, then I think Lp(a) would take on an LDL type of kind of status. And that's why you see the absence and the uncertainty in the guidelines, because there's really no evidence to show us what we should actually do with it. And that really is the fundamental question for the clinician out there in the real world, looking after patients, trying to work out, is my patient at a higher or lower risk of having a heart attack? If I do an Lp(a), will it change what I do, and will that change the outcome for my patients? And they're the types of studies we need to see moving forward.
And so you kind of leave it hanging with, stay tuned, as opposed to it's ready for prime time. You specifically, how would you use Lp(a)? Would you use Lp(a)?
I do use Lp(a). I don't use it in everybody. If I've got a 60-year-old obese guy with an elevated triglyceride, low HDL, a bit of an elevated LDL, I'm going to treat that patient anyway. It's going to help me stratify particularly younger patients. It's going to help me understand the younger patient who presents with an event in whom they don't seem to have any discernible risk factor. But that really is the challenge. That's why it's not quite ready for prime time yet. We really need the data that's going to ask the question, if we do it, what am I going to do to my patient that's different, and will that result in a better outcome for them? Right now, if I've got a patient with an elevated Lp(a), what I'm going to do for them is I'm going to intensify their statin therapy. And to some degree, that's what the recent guidelines really suggest. Yeah. While Lp(a) per se isn't one of the 4 groups that are really referred to in the new ACC/AHA guidelines, you could really make the argument that if you've got a higher Lp(a), maybe that does put you into a higher risk strategy. And in that situation, the guidelines tell you treat and aggressively treat.
So would you say that it had its popularity for a little while, people were very interested in it, and then it kind of tailored off? From these papers in the September 2nd issue of JACC, would you say that maybe now we should at least start reminding ourselves of Lp(a) and maybe paying a little bit more attention to papers like this?
I think so. I think we're learning a lot more about the biology. I think we've got some really interesting therapies that are just starting to evolve and percolate, and if they can get to clinical practice, that'd be great. I think the stocks are on the rise.
Oh, excellent. Okay. The September 2nd issue of JACC, Dr. Nicholls has his commentary, and the paper itself is there for you. For Cardiol Source World News, I'm Executive Editor Rick McGuire.